So I'd like to introduce a colleague of mine and a mentor, Dr. Bohdan Nosk, who's the senior scientist and senior author of this paper that we're going to go over today, which has generated a ton of interest. Bohdan is a professor at health sciences at the Simon Fraser University and St. Paul's Hospital CanFAR chair in HIV/AIDS and research. I've known Bohdan for 6 or 7 years, and you know what he's not? Is an advocate for safe supply. He's an advocate for rigorous science, and we really wanted to bring everybody together here to have a conversation about the methods for this paper and some of the discourse that has fallen out around it. And we just want to have an open discourse. And so I hope everybody here in person and on the screen is ready to participate in that with an open mind. And I'll leave it to Bohdan. Thanks.
Thanks so much, Brittany. Yeah, I'm Bohdan Nosk. My team and I, we took this on at the onset of the pandemic because it was something the province needed a hard answer on. We did the work because we need evidence to support or, stop doing the things that aren't working. And that was really the pretext here. We've gotten a lot of questions before this presentation. We've tried to address them as much as possible, including doing some additional analyses to answer some of the questions that have come up. So I'll do my territorial acknowledgement. How do I advance my slides here? Okay, here. So I'll acknowledge that all of this work was done on the unceded, ancestral, and traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. Our funders were CIHR primarily. Since then, it's been the Ministry of Health that's been supporting this ongoing research, and it is ongoing. What we're presenting today is the first wave, and we'll be continuing on with this research from here on out. All of our inferences, opinions, and conclusions are those of ours and don't reflect the opinions or policies of the data stewards, funders, or affiliated agencies. So the risk mitigation guidance, if you all recall, was released very soon after the pandemic hit in March. The objectives were to prevent the spread of COVID-19 by enabling physical distancing and self-isolation, and offer a harm reduction response to the increasingly toxic drug supply. They included opioids, stimulants, benzodiazepines, and alcohol withdrawal management. We focused primarily on opioids and stimulants. And among opioids, I just want to point out, I think there were some questions. These included slow-release oral morphine and hydromorphone. 92% of all risk mitigation dispensations were hydromorphone tabs. And we could tell the difference between risk mitigation guidance prescribing and OAT prescribing by an additional variable directions for use that we use. It wasn't perfect, but that was one of the questions we had a priori. We could distinguish risk mitigation dispensations from OAT. So what I want to do in this presentation is summarize the design and results of this RMG study. Respond to questions from the scientific and clinical community regarding our analysis and interpretation. It was challenging, and so we're going to dig in there. And we also want to solicit feedback on our plans for reanalysis with this data up to December 2022. So this is an ongoing program. We've just received a new cut of data going up to December 2022, just on Monday. So we're starting this again, and just like we did in this initial evaluation, we're doing all of this on the board with the public involved from the outset. So this is the first step. So our objective here was to determine the effect of opioid and stimulant RMG dispensations on all-cause and overdose-related mortality and acute care visits. So our data sources were British Columbia's linked provincial health administrative data sets. These are all linked by PHN numbers, which everybody who has a care card in BC has at the back of their, or it's at the back of your license. So these are all linked by the provincial government. What we receive are de-identified records, and we have a linkage of 10 different data sources, and they are true population capture for all of BC. The individual component data sets are physician billing records from the medical services plan. These are the key ones, not all of them, but the key data sets that we use in all of this. Hospital admissions through the discharge abstract database, community pharmacy dispensations through PharmaNet. That doesn't include hospital dispensations. That's a blind spot for dispensations in this province. Emergency department visits through the NACRS data set, and mortality through vital statistics and the coroner's services. So right into the methods. First off, of course, RMG was implemented at the population level necessarily without randomization. There's no basis for doing this as a clinical trial. And as you saw in my initial slide, the directions for doing this were nebulous. It was to enable isolation in place, and also to provide a means of separating yourself from the toxic drug supply as harm reduction. So we had no clinical protocols or experience in prescribing, okay? And so that created two different problems for us. First, we needed to find an adequate control group of people who were eligible for RMG, but unexposed. And second, we had to capture the effects of RMG while people were receiving treatment, given that this wasn't explicitly noted for people to stay on long term, okay? And we needed to control for that confounding factors that happen over time. For instance, access to OAT, other acute care visits, access to prescription opioids for pain, things that change over time. We wanted to capture all that to isolate the effect of RMG specifically on mortality in acute care visits. So to construct an adequate control group, that's probably the most challenging element. We did this two different ways. We did it the traditional way using propensity scores for, which is really matching people on all the characteristics that we can measure. And those characteristics were selected via systematic review of everything, of all the factors that we've identified that predict mortality in this population. And we also used what's called a high dimensional propensity score matching algorithm, which sucks out other information, clinical characteristics of these patients while they're in hospital. So proxies of basically disease severity, addiction severity. Two different ways. If we see the same results doing it both ways, we feel more confident, right? If we, two control groups is better than one. That was always the rationale. The other feature that I wanted to highlight was longitudinal matching. We know that the drug use epidemiology has changed drastically even from the onset of the pandemic. The prevalence of benzodiazepines in overdose deaths has swung wildly. It was at 3% in 2017. Now I see that it's up to 40% in 2023. Things are changing in the community. Of course, COVID restrictions went up and down from 2020 to 2022. We wanted to capture all of that. So when we match people, we match them according to when they when they first initiated RMG. And so this is a one-to-one match. Everybody who initiated RMG was matched to somebody who was just like them in the community who were not exposed, okay? To deal with the second piece, we use what's called marginal structural modeling. It's a little bit fancy. It's basically taking into account all of these things that are changing over the time and probabilistically reweighting the sample at every time period to make sure we get a clean effect of medication on outcome, okay? So everybody who received an opioid or stimulant RMG was matched one-to-one to a person who didn't receive RMG. I told you about the longitudinal matching that was done on a monthly basis. Ideally, it could have been done on a daily basis, but this was so computationally intensive, it just wasn't feasible. This took weeks actually to make this happen. So we did investigator-identified covariates and high-dimensional propensity score matching for the reasons I said before. And the high-dimensional propensity scores picked out 50 additional variables out of hospitalization records. Again, all proxies of disease severity, addiction severity, okay? So these are some of the characteristics we captured in the matching and in our time varying controls. So I'm not going to show them all to you. It's too much for one slide, but you get the idea of the extra information we get from high dimensional propensity score matching as opposed to the usual investigator identified covariates. So if you're looking for all of that information, it's in table 1 and supplement tables S9 and S10. So our population, this is a small population that actually received RMG in the first 18, 19 months since it was initiated. Only 5,800 out of what we think is between 200 and 250,000 people with opioid or stimulant use disorders in this province. That's an unrecognized, unmentioned fact of this. RMG was actually quite a small scale program. 91%, most of these people were received an opioid RMG medication, and a relatively small number, and I'll highlight that this was quite small, only 1,000 people were dispensed the stimulant medication, and 535 received both. Some demographic characteristics: 36% female, only 10% in rural regions. Early we wrote that this was largely done in urban settings in Vancouver and Victoria primarily. The clinical profile of these people, maybe not surprisingly, is quite severe. 43% had a prior diagnosis of an alcohol use disorder. 52% were long-time, who had records long-term of opioid use disorder. 25% had chronic pain. 38.5% had unstable housing in the past year, and just under 10% were incarcerated in a provincial corrections facility in the last year. It's not unusual for this population, but it's something to highlight that these medications weren't being dispensed to just anybody on the streets. These were severe cases, people who were dearly in need. So right into the results. Again, this is, I wanted to leave as much time as I could to respond to the methodological questions and the questions on interpretation, so I'm going quickly here. What we did here, each row that you see in these tables is one analysis, one model, okay? So first, without matching, even without much control, we saw that people who received even 1 day of opioid RMG had a protective benefit against mortality. When you matched, when you controlled for characteristics at baseline, that effect was stronger, okay? And this is sort of the most compelling to me part of our results. We saw a biological gradient, a dose response, more medication, stronger protective benefits. Dose response is something, if you think back to your epi textbooks on, Bradford Hill, one of the different criteria for causality, you should see a dose response if you think there's something causal going on, and we did. And this was something that we built into the design explicitly to see if we would see it here. This result, click something. Anyway, I hope. Yeah, so this result here, this subgroup with no OAT for 30 days prior to initiation, this has caused some confusion. So we controlled for OAT access at baseline. So we matched people. Some were on OAT within 30 days of starting RMG, some were not. Our control group had people who were on OAT or not. After initiation, on a week-to-week basis, we controlled for OAT access. So we controlled for it to the extreme. We were still concerned because of the extent of overlap. We just wanted to be sure that even if we excluded everybody who was on OAT in the past 30 days, would we still see the same sort of effect? We did. It wasn't a strong effect. I think you've got a different clinical profile of person here. And it's a much wider effect because simply there were a lot fewer people in this group, okay? Nevertheless, you still see a protective benefit. And we'll get into interpretation of confidence intervals and p-values and all of that a little bit later. Stimulant RMG, again, we saw protective benefits. It was a slight dose response. We see wide confidence intervals because so few people got stimulant RMGs. We just didn't see very many people who got them. I'll get into it later on interpretation. On a per use basis, stimulant use isn't as likely to result in a fatality as opioids, even though a lot of them are tainted with fentanyl. But this isn't it's not out of the realm of possibility. It's what we expected to see effectively. All cause acute care visits, we didn't see the same thing. I'll point out, without matching, the risk of all cause acute care visits was much higher for people who received RMG. So this just tells us the clinical profile of these people. It was a lot more severe. After we matched these people to like individuals, we saw effectively no effect, right? It was right on 1. So that's interesting. We're curious about that. We did see positive benefits for stimulant users, interestingly enough. It's a curious result. We will get back to it, okay? So some limitations. We had to use case finding algorithms to identify RMG dispensations in PharmaNet. Ideally, we would have, and you know what, going into this, we expected to have different drug identification numbers for RMG medications. It wasn't the case. We had to use a free text field. We had 2 different algorithms, one more sensitive, one more specific. Results were consistent. There's a lot of extra work. From 2021 onward, the province now has a stronger identifier of RMG dispensation. So after August 2021, we'll be much more sure of this. But again, we did this 2 ways and the results were the same, so I'm not concerned. Of course, we were unable to determine if persons consumed the RMG medications as prescribed. And, unfortunately, diversion has taken over this story. Our focus here was to determine whether the people who were receiving these medications actually benefited from them. And I think that's the first priority. That is the first question we need to answer. Not everybody sees it that way, but I feel like that was important. And of course, we had a limited sample size and a limited follow-up. We only have a year and a half of follow-up. And keep in mind, not everybody who got, it was a gradual start to this, right? We didn't have a year and a half of follow-up for everybody with RMG. We had people initiating right through to the end of 2021, right? So it wasn't a year and a half for each individual. It was on average like 8 or 9 months, right? So our key messages were that opioid dispensations of one or more day were associated with a reduction in the hazard of all-cause mortality by 61% in the subsequent week. And we'll talk about timing and time frames right away as well. And opioid dispensations, and I didn't get into the overdose related, I just showed you the all-cause results. But when we focus on overdose related mortality, it was a similar sort of effect, okay? It increased, so we saw a biological gradient, a dose response effect. That protective effect increased when people received more medications. It went up to 91% and 89% in overdose related mortality in the subsequent week. So I'm glad we have lots of time to address questions on design and interpretation here. So we received a number of different questions about how we designed our trial and how we controlled for different factors here. So the first question we had, and this is a good one, it's an interesting one. be possible to clarify how subsequent week was defined for outcome ascertainment in the model? How did we deal with timing in our model? Were people allowed to go to be classified as on RMG and in the subsequent week off and on again? The short answer is yes. Okay, and I'll try to demonstrate this with a simple example. It looks like this. Look at that. That's working. That shout out to Michelle Zanetti who did this. I can't do this myself. So this is just a stylized example of somebody receiving RMG medications from week to week. So we had RMG initiation, the star with the circle around it. This was the first dose. This was on like on calendar week. So this person happened to start on a Monday. They received 4 days in their first week. In the next week, they did not receive medications. They did not die. So this is period 1. So to look at the effects of medication and in week T on outcomes in week T plus 1, one of the key challenges is you need 2 weeks to do it. Okay. So week 2, RMG was not received, and so status was 0, and death was not observed. Week 3, medication was received, no death. Week 4, RMG was received in week T, and death was observed in week T plus 1. Okay, so this is timing and how we captured it. So a couple of challenging points. Because we need 2 weeks to do it this way, we realize there could be instances where somebody dies in the very first week that they received RMG medications, and that did happen 4 times, I believe. Okay, so that's challenge 1. Another challenge is if somebody didn't receive RMG in week T, but then received it in week T plus 1 and then died in week T plus 1. In this case, this would have been classified as no receipt of RMG and death in week T plus 1. Okay. Third sort of challenging instance, and this was brought up, I think Dr. Mark Kleinman brought this up, and it was a good point. So what if people were hospitalized soon after they received RMG? Okay, so if they were receiving RMG on Tuesday, Wednesday, Thursday, hospitalized on Friday, for the next week, week and a half, and then died in hospital. So we didn't, and it's an interesting point, we didn't, typically when we deal with OAT and we see hospitalizations, we assume they continue on OAT while they're hospitalized. And so we, when we construct OAT episodes, we connect them. We weren't sure that that was going to be the case. We didn't do that in our baseline analysis. Okay. So we did some more analysis just to kind of, quell any concerns about timing and how we ascertained outcomes. So this was our baseline result, hazard ratio of 0.39, 61% protective effect. If we classified exposure and mortality in week T in the same week, so capturing, individuals who died in the same week that they started, the hazard ratio increased a little bit, but it was still strongly protective. If we allowed exposure in week T or T plus 1 and mortality in T plus 1, almost the same effect. If we incorporated hospitalizations and ED visits, acute care visits, again, we still see a protective effect. It's a little bit weaker, and we observed 4 more deaths, okay? So these deaths, and I don't know that we'll do it this way going forward. I think it's a strong assumption to assume that people would continue to get RMG dispensations while in hospital. And you can tell us what you think. So these 4 extra deaths, people were hospitalized for 15, 17, 21, and 59 days. Is it reasonable to consider those people on RMG, even though they're hospitalized for that amount of time? At the very, I don't think so. I wouldn't be the way that I do it, but at least as a sensitivity analysis, just to be sure we can do this. And I'm pretty confident that we're still going to see a protective effect. Okay. So the results were robust to timing, even if we assumed RMG was continued throughout hospitalization. Second question, a lot of questions about this. Intent to treat versus a per protocol or as treated analysis. A lot of people ask, why didn't we do an intent to treat analysis? In fact, we did, and the results are there. They weren't our primary results, and I'll tell you why. So an intent to treat design is you see it in randomized control trials most often. Randomized control trials have strict protocols where people are meant to start at a dose, maybe titrate and continue on. That wasn't the case here, right? So intent to treat is the effect of assigning a treatment regardless of adherence, treatment receipt, or deviation from any protocol. And a per protocol, or sometimes it's more reasonable to call it an as treated analysis in this case. So we wanted to capture the effect of these dispensations while they are being received, okay? Acknowledging the short-term and sporadic dispensation. Again, this wasn't, not everybody, not all these doctors interpreted RMG as something that you get somebody on and keep them on long-term. For a lot of people, and you look at continuous RMG episodes, most people had 2 episodes. The median duration was, median total time on treatment was 61 days, and the median duration of a continuous episode was only 27 days. And a quarter of these people received, only a week of RMG, okay? So what was the intent in writing these RMG prescriptions? There was no single intent. It could have been to support sheltering in place during COVID-19. It could have been, as it often was, as an adjunct to or means of facilitating OAT induction. It could have been, in some cases, as a standalone medicalized form of harm reduction intended for continued and ongoing prescription. And it's cut off there. I don't know why that happened, but what it says here at the bottom of my slide is it's unknown to analysts at RMG initiation. We can't tell when we look in PharmaNet, when we look in the provincial admin records, what that intent was. And there was no strict protocol. So really an intent to treat doesn't make sense. And it doesn't adjust for all of these changing factors, including access to OAT. So we did it though, and we showed it in our paper. It's in the appendix if you look for it. So on the left is opioids, on the right is stimulants. This is against the match control group after the first prescription was dispensed, okay? So not controlling for anything after. In the RMG group, it could have just been 1 day, right? It could have been a week dispensed, and we're following people up for 72 weeks afterwards. Not much of it's a modest effect. It's still, statistically significant. And with stimulants, it wasn't, although you see protective benefits in both cases. So we still saw protective benefits of opioid RMG and stimulant RMG, although stimulants with a higher degree of uncertainty because so few people got it, okay? So what does that mean? Should we really expect long-term effects from RMG? We certainly don't see them for OAT, right? We know for a fact that right after you drop out of opioid agonist treatment, your risk of mortality skyrockets. It's 10 times higher than when you're on treatment. You wouldn't expect the same thing for insulin for diabetes, right? This is a chronic care. This is a chronic disease. Once you stop taking the medication, it stops working. So part of that, short-term effects that we wanted to capture in the as-treated analysis was acknowledging that we shouldn't expect long-term protective benefits long after these RMG dispensations are given out, right? We're separating people from the toxic drug supply. if they're not receiving RMG medications, they're not being separated from the toxic drug supply. And it's the same thing for OAT. So the biggest questions we had were about OAT co-prescription. OAT is a potential confounding factor in the RMG mortality relationships. So some of the comments we had, we received these indirectly. Investigators did not measure the doses of the two main OAT medications, methadone or bup, in the RMG and control groups. It's likely that the RMG group was on higher doses of methadone or bup than the control group, okay? So that's the first statement here, and we'll address that right away. We looked into our data. So in the top, we've got RMG status at baseline, okay? No RMG, people received a median dose of 100 milligrams of methadone and 16 milligrams of buprenorphine. Among RMG recipients, they received lower doses of methadone and buprenorphine. In fact, that is what we observed, okay? When we stratified by weekly RMG status, so acknowledging that people on RMG, they could drop out of treatment, they could get back on. So this is just when they were receiving RMG. It was the same story, 90 milligrams, 10 milligrams versus 95, 16 when there was no RMG dispensed. So this, the RMG group was not on higher doses of methadone or bup than the control group. And I'm not sure where the hypothesis came from. When I assumed that if you were co-prescribing, that you were going with a lower dose of methadone to acknowledge that you're adding the hydromorphone tab. That would have been my first guess, and it turns out it was true, okay? So RMG recipients received lower doses of OAT overall and during co-prescription, okay? The second statement, the study failed to control for OAT doses in their analysis. We've already told you we matched people on OAT receipt at baseline, and we controlled for it on a weekly basis. That control was a yes/no OAT receipt or not. And it was a yes/no because not all people received OAT. So controlling for dosage in analysis where not everybody is receiving the medication doesn't make a lot of sense in our minds. Nevertheless, okay, so the statement goes, this led them to incorrectly conclude that RMG alone was responsible for the reduction in overdose deaths, whereas OAT likely played a major role. No conclusions can be drawn from the study because it failed to account for OAT. I would encourage researchers to conduct a properly designed study comparing benefits and harms of OAT to those of take-home hydromorphone. So this last statement, we'll get to it this is a separate piece, okay? So this is framing RMG versus OAT directly. That's not how this was done in BC, and that's not the question we were answering. We wanted to know the effects of RMG specifically, okay? But let me address this earlier, the earlier part of this question. So we went back and rethought this, okay? So instead of a yes/no OAT receipt, can we think of this differently? We reclassified the indicator as a 0 to 7 days of OAT receipt in week T, okay? When we did that, things barely changed, okay? They changed a little bit, not very much, okay? We went from a protective effect of 61% to 59%. We also considered a 3-level indicator, and this is weird. We're doing this just to address this comment as best as we can. I wouldn't actually do this. When we go to redo this, I wouldn't do it this way. So no OAT and OAT dose less than optimal, and an OAT dose greater than optimal. Optimal being the minimum effective dose as per the clinical guidelines, which, given that you start low and titrate up to the end of induction, that was anything, and after completing induction, it was 80 milligrams of methadone, 16 milligrams of bup, okay? So when you reclassify this yes/no indicator as a 3-level indicator, the results don't change at all, okay? So reclassifying the indicator variable controlling for OAT receipt on a week-to-week basis had little to no effect on the RMG all-cause mortality relationship, okay? So it begs the question, like, how big would this effect have had to have been to totally confound the effect of RMG on mortality? So we have like bias analysis, we do bias analysis, we can estimate this. So the E-value, and I've left the tab here, you can check out that number if you want to look at the reference. So the E-value is the minimum strength of association, the risk ratio scale that an unmeasured confounder would need to have with both the treatment and the outcome to fully explain away a specific treatment outcome association conditional on measured covariates, okay? So we estimated an E-value for OAT dosing of 4.57. So it would have to be, it would have to be massive to overturn the effect that we have seen. And even just to have the confidence interval cross, it would still have to be a very large effect. It doesn't make sense. I mean, we controlled for OAT receipt. Okay, and this is but this is a relevant question because what we actually saw, most of the RMG experience was co-prescription. A lot of these doctors, I think it was about 2/3 co-prescribed hydromorphone on top of OAT, even though that was nowhere to be seen in the guidelines. And I think this is like one of the interesting and exciting silver lining benefits that we saw in all this. This really helped. It helped retention. When you look at just crude mortality rates, RMG and OAT had comparable benefits. I think OAT was a little bit better. I think this is strictly about dose, right? I think this is just about elimination of withdrawal symptoms. We've got a wide confidence interval here because we saw this so seldomly, right? We can't even report the number of deaths. It was less than 10 when they were receiving RMG only. When they received both, we saw a strong protective effect. And that makes a lot of sense to me. I think since the onset, since we started, since basically fentanyl supplanted heroin as the primary opioid of use on the streets, we haven't fully adjusted to, the added tolerance that we're seeing in people with opioid use disorders. The guidelines haven't kept up, and they haven't kept up because the science isn't there. Nobody has seen as much fentanyl as we're seeing in BC right now. It's a scary thing. This is a really positive finding. Combination OAT may be a very good thing, and we need to test it more carefully. Yeah, I mean, it's a positive thing. We have investigated this separately as well. We have another paper coming out. It's in second review right now, looking at the subgroup of people who initiated both RMG and OAT at the same time. Okay, and so adding RMG helped a lot. It improved retention enormously. And whether it was started at the same time or it was added on mid-flight while people are on OAT, it had a strong increase in the odds of retention in the subsequent week. So it was a really good thing. Look out for this. We would have been done this already if we weren't answering questions on this first study, but give us some time, we'll get it out, you'll see it soon. And all of this is, we've got to highlight here, we're in a state of crisis. OAT retention has been on a free fall for 12 straight years. We need every option that we can to reverse this. This is our best tool to keep people alive, and it's becoming less and less effective over time. So this is a really welcome development. I hope, I see RMG on a continuum, right? This can be a first step. It can be harm reduction. It can be added on to OAT for people who want it that way. We need more tools in our toolbox, not less. So I think it's needed, and I think it's a really positive result that we've seen. On to inference and interpretation, the p-value. A non-significant effect doesn't mean no effect. And there's a really good paper from some of the leaders in our field on, and this is a big movement to, eliminate our reliance on p-values for inference, okay? A non-significant effect doesn't mean no effect. And this is an error I've seen even locally. This is ingrained in our language, in the way that we're thinking. It's wrong. Now, you've seen some of our effects as being not statistically significant. They were not statistically significant, and especially the opioids versus stimulant. They were not statistically significant because we simply not many people received them, and we didn't get much follow-up. So how do we get statistically significant results? Well, we need longer follow-up and more deaths, okay? That's what it amounts to. So how long should we wait? How many more people need to die before we get a solid answer and decide how to proceed with this? That's what this comes down to. Sorry, I'm getting a little heated, but it's an important thing. We need to think critically about this. So for stimulants, the risk of per use mortality is lower, and so you wouldn't expect as much of an effect. There are a much smaller number of stimulant drug recipients compared to opioids, and the result is a more modest effect in mortality and higher degree of uncertainty, so wider confidence intervals. We will reevaluate this with more data. So one of the last, this might be the last thing I'm going to cover, is acute care visits. Why didn't we see an effect on acute care? It's a good question. We expected to, if it's preventing mortality, it should have prevented hospitalizations and ED visits. Why didn't we see it? This question supposes that, okay, so I'll just read it out. It's a little tricky. Paradoxically, the RMG group, despite having a lower overdose death rate, and I added that in myself, I assume they're meeting death, had a higher rate of acute care ED visits for overdose. It wasn't just ED, it was hospitalizations as well, right? This makes sense if the RMG group was attending the pharmacy and clinic more often than a non-RMG group. The physician or pharmacist would call the paramedics if the patient showed signs of an overdose or serious infection. So if they're in the system more, they're seeing their doctor more, they're more likely to be seen in hospital. Okay, that's the premise. In other words, frequency of clinic visits could also be a major confounder that the study didn't control for. The RMG group probably attended the clinic and pharmacy more frequently, was thus more likely to be sent to the ED. This would also have a spuriously inflated the association between RMG and overdose and total mortality. Okay, so first we controlled for provider attachment, whether they had somebody that they regularly went to. Also, when we captured RMG dispensations, OAT receipt, benzo receipt, others, we're effectively capturing interactions with pharmacy and doctors, right? If they're getting those medications, they're seeing doctors. So those effects are captured. We can't, keep in mind, we can't capture clinic visits specifically. We have the alternative payment plan here. Anybody who's going to a community health center, we don't see those physician billing visits. So it's a little, but anyway, we captured this effect with these two covariates. The interpretation, so what this is implying is like a surveillance or a detection bias. I think that's plausible despite our controls, but I think the converse is equally plausible, that people not seeing a doctor, not in touch with the system, is more likely to end up in acute care. I personally believe that explanation more than the contrary. And the alternative, and this is like a pervasive thing, we've been seeing a lot of these strange results when using acute care as an outcome in some of our other analyses, and we're kind of scratching our heads about it. What I think is happening is people are using our acute care facilities for outpatient care. And that's an indictment of our system, right? It's a big problem. When we tracked when we tracked 30-day readmission rates, the 30-day hospital and ED readmission rate in this province, province-wide for people with opioid use disorders is 50%, 50. That is a problem. That is, that revolving door in the acute care system, whether it's ED or hospital or detox, this is the point of first access for people. It's not a good way to care for people. It's not an efficient way to care for people. It's a part of this problem that we really need to address. And it's an artifact of the constraints we have, right? We just don't have enough clinics, enough doctors, enough contact points for these people to reach. And so they're ending up in emerge. So that's a sad result of all of this. Last, on diversion. So yes, there is an urgent need to study the harms caused by diversion and unsupervised injection of take-home hydromorphone tabs. These harms were not addressed in the study. They weren't addressed. Our first priority was to determine whether the intervention worked for those who received it. I'll point out that 92% of these opioid RMG prescriptions were prescribed daily. Okay, so yes, they got a pill bottle and they took them out, but they were still coming into pharmacy daily. I want to ask, is there any hard evidence other than anecdotal evidence to say that diverted RMG medications are leading to increases in new diagnoses or mortality? It's an open question because I haven't seen it. And we went to great lengths to prove this effect with as hard of evidence as we could and interrogated it to the nth degree. So I would like to, if you are wanting to put a stop to this on the basis of diversion, bring us the evidence, because I don't see it. The second question is, should some or any diversion preclude the continued use of PSS and RMG? Is diversion explicitly a negative? It's a very controversial statement. Are diverted medications going to exclusively to kids in high schools given out before they jump on the school bus? I doubt it. I believe if they are being diverted, they're being sold to other users on the streets. And you know what, using a hydromorphone tab as opposed to injecting fentanyl or smoking fentanyl, maybe there is a benefit there, okay? At what point does this become a net negative? That is ultimately the question. Do we want to stop doing this, even though it is producing some benefit for the people who are receiving these medications? That's a difficult question to ask. I want to point out a few things here. Opioid use disorder diagnoses have been on a steady climb since 2003. Since 2003, every year they've gone up. They spiked in the fentanyl era just because of detection. They came down, not quite. 2020, we didn't have the full year of data. So I'm expecting after this spike that they'll continue on this trajectory. This is a sad thing. More often, lately, these people are presenting with no contact with the healthcare system in the past year, okay? So this has been a problem. New incidents has been a problem in this province for 20 years. It's been a growing problem for 20 years straight. Since COVID, we have not seen an increase in new opioid use disorder diagnoses, and we haven't seen them for people under 19. This is a more recent data set. This is the PANDA platform at the CDC. And they're low compared to the other groups. This is mostly driven by 25 to 44-year-olds, okay? So if diversion is happening and if it is causing harm, we need to capture it. Where can we capture it? I think if you had electronic medical records, if you had access to electronic medical records and urine drug screen results, you could see it there. That data is not collected routinely and it's not linked with the provincial data. That is a weakness in our surveillance system that needs to be addressed. We need to see it. And I hope we will see something to this effect. It's not just about prescribed safer supply. We need to be on top of the new drugs that are being used. Right now, we're only seeing them in deaths. That's a bad way to capture this, right? We need to be on top of it. And just to point out, this is a fentanyl epidemic. 85% of our deaths, our overdose deaths, are fentanyl related. And that hasn't changed in quite some time. Other, benzos are something that really spiked, have come down in 2022, and they came back up in 2023. This is changing without our, we certainly have no way of intervening on this. This is happening in the background. We're trying to respond as best as we can. And this statement from the coroner's service says it all, right? So hydromorphone has been detected in 3% of of deaths in 2023. Illicit fentanyl present in 85%. It's scary. Their latest reports, this link, they don't have this up here anymore. They have more recent stuff. We're starting to see more fentanyl analogs being detected at a high percentage, right? Fentanyl, there's a whole class of drugs. There's hundreds of them. We will continue to see new, more potent strains. So we need to keep on top of this. And again, we see fentanyl to an extent that nobody else, aside from our neighbor Alberta, is seeing. The scale and scope of our crisis, I don't even think people fully understand it outside of this province. And the most devastating things that I've seen in our data, you haven't even heard about. Perinatal care in this province for women with substance use disorders is an absolute crisis. And that is, I struggle with this work because it takes time out of other things that we're doing. We need refined clinical guidelines. This data is the best data source we can get to tell us exactly what is working for people with fentanyl, who are using fentanyl. Perinatal care, we have linkage for mothers and their children for up to 20 years. And so we can see what is happening in that realm. That aspect of care, that subpopulation needs a lot of attention. It's taking us away from that kind of work, and it's an internal struggle. I really struggle with it, I do. Effectiveness versus cost effectiveness is one of the last questions. The data suggests that at best, RMG per 100 people saves maybe one life after 72 weeks. At what cost? An actuary wouldn't be impressed at this result, pretty sure. First of all, I think it's a pretty callous question. I didn't like how this was framed. Every life matters. If we can save a life, it's worth pursuing. That said, this isn't a question about effectiveness. It's a question about cost effectiveness. And this is something that is on our radar. We are doing it now for RMG as it was done in the initial 18 months. And we're also considering the potential value and long-term impact of other plausible stakeholder-defined strategies to expand and refine the implementation of risk mitigation guidance. This is something that we conceived in 2020, 21. We knew that prescribed safer supply was going to be very limited. And if we were ever going to expect this program to have a large effect, it would have to change. And so we're trying to consider what alternate versions, whether this is non-prescriber based models, what kind of impact that might have for the province and whether it'd be worth it. Somebody asked us about the number needed to treat. It is not something I normally do. I don't exactly know how to interpret this or whether this is an appropriate interpretation, but we estimated, we're doing it because somebody asked. So 96 patients are needed to receive opioid RMG continuously for 6 months to prevent one death. But keep in mind, most of these people were just getting it, a quarter were just getting it for 1 week, or they were getting it tacked on to OAT. So it's maybe not, I don't know how directly interpretable that is. Okay, I'm going to end on a note on scientific discourse and public communication. I want to choose my words carefully here. So we are in the fake news era. I think there is, a war on truth that we have to consider ourselves on the front lines of. It's our job as scientists and as clinicians to speak truthfully as much as we can and to speak on the basis of evidence. I am a believer in evidence-based decision making, and that's what we're trying to bring to this problem. The division that I see in the community of addiction medicine is really, really concerning. It's damaging. It's bad for patients. It's bad for the community at large. When we talk to the media, when we do our research, we have to keep that in mind. Are we doing what's best for patients? Are we doing what's best for the public? I'll leave it at that. So we are updating this analysis. And just as we did the first time around, we're soliciting suggestions for updates on this design. So we're taking this same cohort, same data, updated to the end of 2022, and we just got it this week. All of our prior, everything that we've done, we'll do it again, just for comparability. We'll extend it with more follow-up, and we're considering some additional work based on the feedback we've had, based on requests we've had from the Ministry of Health. So people want to see a lot more descriptive data on dosing, characteristics of new initiators. We had some questions from the field. How have new initiators of RMG changed over time? It's an interesting question, right? Somebody who got access in March, April, May of 2020 versus somebody who's just accessing it in 22, it's a different patient profile. And so that's going to be interesting. And how these, how the medication is being used, how it is being dosed, and how it is being dosed alongside OAT, I think is going to be really important as well. As far as like the analysis goes, we've got a couple of ideas. So we want to do a sequential cohort analysis. And so this is extending this idea that the patient population has changed, and maybe with a different patient population, maybe the effects are weaker or stronger. We don't know. We can try it. I don't know what the numbers are like after how many new initiators we actually have after August 2021. With all the bad press, we know that physicians were deprescribing already. So, this is going to be subject to sample size considerations, but we're going to give it a try. Instrumental variable estimation is, it's controversial. It comes out of economics. Epidemiologists don't like it, but it's another way of controlling for confounding at baseline. So it's an alternative to propensity score matching. Propensity score matching has the underlying assumption that all of the factors that go into choosing a person for the medication are measurable. IV estimation is assuming that people are selected on unmeasurable factors. The strength of your IVs, usually the instruments that we use are about prescriber experience, right? It's about what the prescriber has done in the past and how influential that is in their decision. So that's why we didn't do it the first time around, because there was no experience in prescribing hydromorphone or these stimulants in this case. We may try it once we have a little bit more data. And then we'll do more sensitivity analysis on RMG, OAT exposure, and outcome classification based on some of the feedback that we got, which was really, a lot of it was constructive and quite reasonable. So we thank you for that, and we'll consider it. So we have some time now. Thanks for sticking around. I'll take any questions, and just keep in mind, this will be recorded and available online for anybody who wants to see it. Yes, thanks.
So given what you said about the ever increasing concentration of fentanyl,
Yeah.
the emergence of new adulterants, Mintees work showing a very strong association between fentanyl concentration and the actual overdose rate.
Yeah.
Are we getting to a point where in longitudinal analysis of mortality or even non-fatal overdose, we're going to have to find some way to adjust for changes in the drug supply?
Yeah.
But can you just summarize the question?
So the question is about mortality in this province and adjusting for the illicit drug supply. I think it's an important part of everything that we're seeing. We would not have seen the spike that we started seeing in 2016, if not for the arrival of fentanyl on the streets. It's gotten even worse since then, right? It's benzos now, it's a mixture of a lot of different things. So yeah, we need to acknowledge that. What did you have in mind, Thomas?
I don't know, I was like thinking fentanyl concentration or something,
Yeah.
or, emergence of, new adulterants. I'm just sick of, presenting on, positive impacts of new emerging interventions. People say, but your death rate keeps going up.
Yeah, I mean, the simple conclusion is, and I see it in newspapers, safe supply comes on and death rate goes up,
That's from the New York Times.
Yeah, really, huh? Yeah, well, I mean, correlation doesn't equal causation, and RMG was a very small group of people, and that very small group benefited from it. So I don't know what to say. I mean, we need to work better with the public to communicate and educate the public on what we're seeing and how to interpret what we're seeing. Jill?
Yeah, so first, thank you for the presentation.
My
and
pleasure.
Also the passion and heat that you're bringing.
Try to keep that contained, yeah.
Yeah, no, and I will say my passion and heat is Indigenous, working with Indigenous health
Yes.
groups and populations. So were Indigenous self-identifiers collected, and was there a separate analysis done on this? And I was going to ask Ricky what you're presenting too.
Yeah.
And the reason that I say that is because these results are so important to get out there and looking at the research group at Kilala, health
Yes.
center downtown.
Yeah.
And taking a look at safe supply in the context of a relational model of care.
Yeah.
Because they're seeing actually that the medication on its own is working. So
Yeah.
it'd be very interesting to see a sub-analysis of Indigenous peoples and how that.
So we're lucky and honored to be working with First Nations Health Authority. The First Nations client file is linked to this database. We are planning on a sub-analysis on people with First Nation status. That hasn't happened yet. And it hasn't happened partly because of the immense amount of effort that went into all of this, but also what we've seen in perinatal care. And that is FNHA's primary priority right now. Brittany, do you want to speak to it?
The only thing I would say is that we don't have Indigenous identifiers in administrative data. So it will just be limited to status First Nations and people who are part of the First Nation client file.
Yeah.
So it'll be an underestimate, not of Métis, Inuit, people who self-identify as Indigenous.
And when you do that, I just encourage you to reach out to like David and folks at Colin.
Yeah.
That might be a really nice collaboration. Like
I don't know if
yeah.
it'll ever get published. I don't know what, like, it'll go to the First Nations Health Council leadership, but there might be a way to do internal sharing. So
Yeah.
I'd be happy to connect with you after, or David.
Yeah, totally. Because
Yeah.
I just see like an absence in the literature. Like I think a lot of people hear, Indigenous health research and you think like qualitative, and they're actually left out of a lot of these types of analysis, right?
Yeah.
And especially when public and then like informing health interventions specifically for Indigenous people. So it would be great, like Kilala has 1,800 members. We have a massive OUD safe supply data set, right? And so we're looking at that in the context of relational model care. And it would just be really interesting to kind of see that analysis done and hopefully get published or even results internally.
Mm-hmm.
But talk to David.
Sharing
the
for
folks
Indigenous partners.
Exactly, that's something.
Let's connect after.
Yeah. Okay.
Thanks. We've actually done a lot with this data with FNHA. A lot of it you won't see. A lot of it is for FNHA explicitly, and that's totally fine with us.
Yeah,
Yes, yeah.
That's how it should be,
Yeah.
right? And it was, and as long as it's kind of like benefiting, contributing to that.
Yeah. I'll take another question here. I don't want to miss people in chat. I see some. Yeah, Rupi, please. Yeah.
Presentation. I'm a prescriber of these medications, and so just from my perspective, this is really important, and we're really grateful for your work. A bit on Thomas's point about the changing drug supply, and now, we see a rapid decline in hydromorphone prescribing, and how it's going to impact the work that you're doing. But also to keep in mind what Thomas said about the drug supply, as all of you are aware, it's so much more toxic.
Yeah.
And we don't actually have the appropriate medications at our fingertips to do safe supply.
Yeah.
And the stigma, the non-prescribed model being a key piece, but just, letting everyone knows this.
Yeah.
My concern moving forward is that sharp decline in prescribing and the ability to, and not having those medications being a primary reason that I can speak to from folks that I work with.
Yeah.
not prescribing or there being a decline, right?
Yeah.
Because people are in a different place than they were definitely 2020 and 2021.
Yeah.
And so I think that really has impacted the numbers of hydromorphone prescriptions. for
Yeah.
example. But anyway, thank you for your work and
It's my pleasure.
a really great presentation, and it helped clarify a lot of things for me. So thank you.
Great. Thank you for your work,
Yeah.
Rupi. You know, we're behind the desks. We're doing our part and, you know, you've got the hard work on the front line. So thank you.
And I will say in the updated, we're including the fentanyl products that people are now able to prescribe. So Fentora and fentanyl and the patch will be included. We're in trying to figure out how to get the tins for that.
Okay, so I'm gonna go to the chat here. What was the first? Okay. So I see a question from Jay Wortman. From the perspective of an OAT prescriber, it would be important to know the relative benefit of OAT alone or OAT plus RMG. So I think I showed you that. At least the crude mortality rates are a lot lower for people getting both. And I think that's that's just dosage, right? That is total opioid dosage. That's telling us that OAT alone isn't cutting it. The fact that you see that big of a decline. Right. So I think I hope that answers the question, Jay. Please speak up if you'd like me to say more about it. If there are other questions from people in the room, I'd happily take them. Just Sean, are people able to unmute themselves now? Yeah. Okay.
There's more in the Q&A too. Can you see?
Is there?
Yep. There's 3.
Okay. Where are the questions? Okay. Okay. So where was that? Why do I not see it? Q&A. It's not in chat. Okay.
Technology.
I don't know. Just think it's.
I'm not seeing it in mine, but okay. It's probably because you're the host, right?
Right.
Okay, Yumi Yamagami says, I'm wondering how you could treat young adults who do not tell anyone about their addiction. I'm thinking back what we could have done thinking about our son's death of fentanyl. I'm sorry, Yumi. Nobody, including his friends, knew he was taking it, so it was a shock to everyone. The initial step is to get on board of the treatment, how to reach who hides their addiction. Man, is there I'm sorry for your loss, Yumi. I wonder if somebody in the field has has an answer here. It's not, you know, as a scientist, is not entirely in my wheelhouse to know how to answer a question like this. You wouldn't want me treating your patients. I don't have a very good bedside manner. Rupi, what would you say to that question?
The first thing that comes to mind, Bodan, is stigma.
Yeah.
So we, as a society, using compassion first.
Yeah.
And realizing that this is not, you know, an issue based on someone's, you know, character. This is absolutely not that. And very frequently this becomes a medical, you know, a use disorder that requires compassionate, continual care. So as long as our health services, for example, there can be several access points. Someone can present and not be turned away. And,
yeah.
And then in society in general, that we can ask them the right questions from an early age. And I think stigma is just the one thing that is holding us back.
It's the shame that goes along with it that keeps people from asking for help. Could say the same for mental health conditions, right? Thanks. Thank you, Ruby. Are there sufficient numbers to be able to include other novel prescriptions for PSS and BC in a future analysis, i.e. sublingual fentanyl tablets, fentanyl patches, oxycodone tablets? So I guess this is about sort of off-label PSS, which I've heard is happening. We can look for it. It's not really explicitly what we're supposed to be doing, but I know it's happening, and it could be happening on a large enough scale that it could warrant. It's a good suggestion, Ryan here. Ryan, that's a question from Ryan Harriet. So we'll look into it. You know, a common concern, and Rupi voiced it earlier, these medications aren't potent enough and not enough people want them. It's not strong enough to address their concerns. It's a difficult situation the province is in. You know, you can't prescribe fentanyl explicitly, they can't get Health Canada approval to do a broader breadth of substances here. So it's a regulatory issue, unfortunately.
We're also doing the survey. So we're doing a prospective survey of people who
Right.
have had receipt of PSS in the last 30 days. And oxycodone and fentanyl products are really high. Dilaudid or hydromorphone is still the highest that people are reporting receiving. And then we're asking for permission to consent to link to their administrative records through date of birth and PHN. So we'll be able to see exactly what they got that way too. So more to come. It's a giant evaluation.
Thanks. Yeah, there's a
Karen.
prospective cohort study being led by Karen Urbanowski and Bernie Pauley at UVic that is asking, that allows for self-report. And you,
Yeah.
of course, Brittany, sorry.
Bernie does the qualitative.
Yes, Bernie's the qualitative
So we're
person.
looking at this from a whole bunch of angles.
Yeah.
Lots of interviews with prescribers and health planners and stuff too.
Yeah.
So suites of papers are under review.
I should have mentioned that the admin data is one piece of a broader study. Qualitative research, both with patients, prescribers, policymakers, and a prospective cohort study that is going to link to health administrative data. Yeah, thanks. Trish Caddy had a question. Thanks for this dissection of this important study. I'm wondering, given that youth have fewer chronic medical concerns and are generally hospitalized less or see their doctors less capture, and given the time it takes from first use to developing a use disorder, is there concern that increased access to tablet RMG may contribute to downstream increases in use disorders when these youth become young adults? Thank you again. I mean, yeah, that we should be concerned about that. We should be monitoring that. If youth are coming and presenting to the system with a use disorder, we need to treat them. If OAT isn't working, we need other options. Not everybody wants OAT. That is a big challenge here. There's a long history of sort of paternalism. No offense, not specifically to you, Rupi, but we hear about it when we speak to participants and the people with lived experience in the field. And it's paternalism in care. It's
Liquid handcuffs.
right. Yeah. Liquid handcuffs is what it's referred to on the streets, right? This is not a desirable option for a lot of people. And so we need a breadth of options. There's no magic bullets in public health, and RMG isn't a magic bullet either. Prescribed safer supply isn't a magic bullet. So I'm glad we're having a broad discussion about this, but it can't be the only discussion that's happening. And it's kind of taking all the air out of the room, frankly. So it's something that we will continue monitoring, Trish. Thank you. Okay, and that's the third one, I think, is Jay Wortman. I think have I answered that question? Yeah. Lawrence Bosley. Okay, so there's been much attention paid to the increased risk of opioid overdose death when benzos have been part of the picture. RMG benzo prescribing wasn't addressed here specifically, but is there any signal around risk regarding the benzo RMG? Yeah, that's a good question. What do we do about benzos? I mean, what we see is people who are being co-prescribed benzos and OAT, and we saw this a long time ago, they're at drastically higher risk of mortality. I have no idea whether that risk is medication or indication, if those people are sicker to begin with, or it is actually the medication that is causing them greater harm. And I have a great deal of difficulty answering that questions. Benzos are prescribed for a whole wide range of reasons. I hear a lot of off-label prescription for stimulant use disorder. It is a major clinical challenge. And, in conversations with Paxton Bach, your colleague, one of the developers of the clinical guidelines here, it's a major challenge. I wonder if we can and we will look at benzo RMG prescribing. We simply didn't know what to do with it and how we could adequately answer the question of what it's doing. Rupi, I'm sorry to pick on you, but you're here, so yeah. No, please.
If I could just say, having working in detox, you just realize quite quickly that somebody who's been getting benzo down may not go into any benzo withdrawal or have a severe seizure.
Yeah.
It is such a variable thing in
Yeah.
terms of how much they're getting, the potency of it, and some people are still incredibly sick from it. It just makes it really challenging to be able to guess, really, because that's what we're doing, how much to give somebody.
Yeah.
To help them taper
Yeah.
down from their street use, but then you can
Yeah.
never give enough so they continue to use, to not be sick, and then have we then increased the risk of death?
Yeah.
Because like you said,
Yeah.
you do have data that shows that co-prescribing increases the risk of death. It is such a challenge in the community, and it also makes RMG a challenge because then you're not dealing with the other half of the problem.
Yeah.
They're still suffering from the benzo piece.
Yeah.
Do we start prescribing or not? It is such a conundrum.
Yeah.
and a
Yeah.
challenge.
Yeah. Rupi Brar, my co-presenter for the day. Thank you, Rupi. Yeah, and I'll just clarify again, people who were co-prescribed both had a higher risk of death. I don't know, I'm not confident enough to pin that tail on that donkey. I think there's equal argument that this is about the patients who are receiving them as it is about the medication. And I don't envy you. Again, 40% of deaths in 2023 had benzos indicated in toxicology. It's a massive part of the problem. And it's come out of nowhere. It was 3% in 2017, 3%. Okay, I think that's the end of the questions. One more? Oh, anonymous, okay. Thank you so much for your research and passion. I'm wondering if the conclusions are in part based on an assumption that the patient receiving RMG is actually ingesting these meds. Good question. It is possible that they are selling them. Yeah, it's a diversion question, which is a bit like contingency management and motivation to continue daily pharmacy visits. Is there any consideration to paying folks in cash a similar amount when they pick up their daily OAT to see if there are similar benefits to RMG? So that's contingency management. That's what we call contingency management. And I'm going to address this question. Anonymous participant, it's the dose response that convinces me that this isn't just an income effect. Okay. And I'm glad it came up. I meant to remind myself to say it, but I forgot. So thank you. The fact that we see this big a difference between 1 day and 4 day prescribing tells me this isn't just about the income that they receive. If you can make some sort of indirect argument that greater income leads to greater food security, housing security, and there's some protective, indirect protective benefit. Even if you convince yourself that this is an income effect, the difference here, I just don't buy it. I think this is something that's real. Please, Thomas.
Well, the only thing I just add is Lindsay Richardson's work has shown that
Right.
small increases in income among highly vulnerable individuals actually result in typically more harm
Yeah,
than
Yeah.
less harm. And
Exactly.
You actually have to, there's kind of a line there that you have to cross, and it's quite high for
Yeah.
income.
yeah, that's a good point.
So, picking up a few extra dollars for diverting a few
Yeah.
is probably going to cause more harm than
That's right. It comes along with the assumption that people are using that for food and for housing and things that protect against mortality as opposed to street drugs, right? Which increase, which we know happens.
But we know both.
Yeah,
The diversion critics are, the RMG critics who are, raising concern about diversion. The main narrative is this stuff is getting sold for fentanyl.
yeah,
So
Yeah.
if the concern is that people are getting RMG and they're selling it, well, if we follow that line of reasoning, you would only expect more money.
Yeah, it doesn't work.
It doesn't jive.
Population.
yeah. Our results don't jive with an explanation that this is, that these benefits are from income generation. I don't buy it. And again, it's the gradient that really convinces me.
You didn't show it with a higher morphine equivalent, so we also did it that way.
Right.
Higher doses
Yeah.
people were getting, the more protection they had.
Yeah. And this wasn't just,
another way of showing that.
that's right. This wasn't just days prescribed. It was total dosage within the week. Okay. So one question from Patrick Stell that I think just came in. Is there data on ED visits and hospitalizations for youth for OUD and whether these are increasing or decreasing? Yeah, we have data. We have data for drug-related, overdose-related, even any all-cause visits for youth, for any age group. We can present that. That's something that we routinely present to ministry, and we'll keep our eyes on that. Thank you, Patrick. If there are no other questions, should we cap it there? I'm looking around my audience. Everybody's getting anxious in their seats. Thank you for showing up. It's nice to be in Hurlburt again and have a normal scientific presentation. I'm glad that this work is being presented in this kind of venue. I think this is what we need. So thanks. Thank you, everybody.